without further ado, I'd like to introduce Professor Chris Andrews from Calgary.
Thanks, Cindy. So, welcome. It's a pleasure to talk to you. So, I'm a gastroenterologist, and I specialize in motility. And I work in Calgary, which is in Canada. And you may wonder how I got involved with the company, but I was actually doing a sabbatical there in 2020, just as they were launching the company. And so full disclosure, I'm actually now the Chief Medical Officer. So very involved in the company and in sort of directing the clinical strategy. And so I've actually had the benefit of having the device available for my use for my patients in Calgary for the last 2 years. So as part of, obviously we're recruiting for research studies, but I've also been able to use it for my patients and give the results and help use those results to guide their management. And so I'm going to actually present a couple of cases today, which is actually demonstrating how it's been useful in my practice. Whereas most of you, if you're doing research with the device, obviously it's in the context of a clinical trial. So a different angle. I should also point out, just for disclosure, that Alimetry is not approved in the EU as yet. That's in process, of course, but it's not. It's certainly you can do it through a research protocol in the EU, but it's not clinically available as yet. So the spectral analysis is one of the two main outputs of the report. So there's the spectral analysis and there's the symptom analysis. And as you can see here on the top, what you're seeing is the spectrogram, and that line, the yellow line at 3 counts per minute, is showing you how stable the gastric electrical activity is, the slow waves of the stomach. As you saw in the initial diagram, 3 times a minute, you've got these waves of depolarization or electrical activity that go from the top of the stomach to the bottom. And when that gets disrupted, we think that becomes a problem. That becomes a disease state. And so the frequency band shows you where the frequency lies. It says sort of what frequency over time. And it also shows you how stable it is, okay? Now below, you can see the amplitude of these electrical waves. And in the baseline state, as you probably know, the test is a 30-minute baseline, then you need a standardized meal, and then you have 4 hours afterwards to monitor the meal response. So in the baseline, generally it's quiet, not always, but generally it's quiet. And then when you eat, the stomach ramps up and the contractile activity increases. The electrical activity increases, and so does the contractile activity. And then you can see it tapers off over time as the stomach empties and the meal is processed. And the data is actually coming out pretty fast now in terms of we now have normal values, okay? So over 100 healthy controls across male and female, ages, ethnicities. And so we are able to actually get a number of metrics that are normal values. And they've also come up with a couple of new metrics to better characterize these spectrograms. The first one is the gastric alimetry rhythm index, but put very simply, it's just a measure of how stable that 3 count per minute band is. And it's the amount of time where it's at that baseline rate. And so a value of 1 would be that it's completely at 3 counts per minute, and a value of less than 0.25 has been found to be our cutoff in the normal controls. So often when you eat, there might be a little bit of noise or a little bit of artifact or a little bit of variability in that rate of the waves, but generally it should be above 0.25 of the stability. So the straighter and the more yellow it is, the higher the Gary is going to be. The principal gastric frequency, that's actually been the sort of the hallmark number for traditional EGG, where you just measure, is it around 3 counts per minute? And we definitely found that with body surface gastric mapping, it's much tighter range than electrogastrography used to be, so it should be between 2.65 and 3.35. And then we also have the fed to fasted amplitude ratio. So a meal response, you should see an augmentation of the amplitude after you have a meal. So generally, it's quiet, you eat, and it should be at least greater than 1.08. And the reason that this one is a little bit less robust, being that sometimes you may actually have an MMC happening at the baseline, and then that makes it seem as though there's not as much augmentation with the meal. And that's an avenue for further study for sure. And then finally, just the average amplitude. So generally, your stomach, the amplitude should go up a certain amount, but we realize that the BMI really makes a difference. So the higher the BMI there is, the more it attenuates the signal. So the Alimetry device actually adjusts for the BMI, which you enter the BMI when you start the study. So that's very important to adjust it for BMI, because if you just have a regular value for everybody, it might be a lot less accurate. So those are the normative values, and a guideline to interpretation actually just came out last week as well, and that's open access, so you're welcome to read that over if you like. And so after doing this for a time, and we've now done many, many hundreds of studies, over 1,000 actually, we've found some phenotypes, what we call phenotypes of these patterns of the spectral analyses in disease states. And when you look at large groups of people with chronic nausea and vomiting, dyspepsia, gastroparesis, you can see that a lot of them have patterns that are abnormal. And so probably the ones that are obvious are the high amplitude and the low amplitude, where the actual counts per minute are above or below 3. And the one in the middle, which is what we call the dysrhythmic one, where the stomach is actually not able to generate a normal 3 count per minute rhythm in an organized fashion. And so that dysrhythmic one is a pattern we actually term a neuromuscular pattern. We say that it's probably due to the fact that there is some damage either to the enteric nervous system or the ICCs that is not allowing the stomach to generate the normal response to a meal. Other phenotypes that we have seen are high and low frequency, and high and low amplitude as well. So very high amplitude, a lot of these are just empiric, right? They're just patterns that we've noticed, and there's still a lot of work to be done to understand whether or not or how the pathophysiology equates to these phenotypes. But they do come out quite recurrently. And then looking at the phenotypes that are symptom-based, there's 3 rough ones. There's actually a few more that we're still discussing on what's the best way to present them. But the main ones would be on the left would be what we call the gastric sensory motor profile. And those are ones that are meal responsive. So their symptoms are not that high. They eat a meal and the symptoms go up, and then as the stomach empties off and stops working or ceases the meal response, then the symptoms ease off. The second one is more a continuous profile, where the symptoms are there at baseline and they really don't change that much with the meal. And these obviously very closely can relate to the functional dyspepsia subtypes. So, the postprandial distress syndrome and the epigastric pain syndrome. So those would be correlates in our mind that you can see that real time. Of course, it's not the same as doing the Rome survey, but it, we do feel that that's a correlate. And then situations where the symptoms actually go up towards the end of the meal, which we're terming post-gastric, perhaps more related to small bowel. And so you already saw this slide. It gives you this in the report, and it's all tabulated. They can also put they have a plot where it shows you how much more or where the symptoms lie in terms of more EPS or PDS type symptoms, and how much it's related to the gastric response. So anyways, here's a couple of cases. I have 3, and these are all real cases. The pictures are stock photos, though, okay? Just so you know. But here's a 79-year-old male who actually was relatively well until he started getting postprandial nausea and vomiting in his mid-70s. And he got to the point where he really couldn't take anything by mouth, and he was actually unable to complete a scintigraphic study because he couldn't take the test meal. And he had no suggestion of any pre-existing psychiatric disturbance, and he actually had quite a comprehensive evaluation for all sorts of unusual things that might cause this sort of problem in a 70-year-old, including amyloid and CT scans, and look for structural things and autoimmune and so forth. And we did the endoscopy, and there was no gastric outlet obstruction. There was perhaps some retained food, but when we looked at his spectral analysis, it was pretty clear that there was some disruption there in the stomach, spectral function, and when you sort of go through the approach, the Gary was low, so you could see that it's less than 0.25. It does read it out for you, and it gives you an hourly value. The amplitude was also low, and the meal response was also poor. And so, there may have been a history of possibly an infectious onset with this person, but this was a puzzle that we really did not know what to do. But it was very clear that he was losing weight, and so based on this, it was what we call this neuromuscular phenotype, and our clinical diagnosis was that he did indeed have idiopathic gastroparesis. Now, he had already been diagnosed with that clinically, but we really didn't have anything to confirm it. But as you know, with gastroparesis, there's the group that we think is an organic neurodegenerative disorder of the gut, and then there's the other group that may be more like a functional dyspepsia type picture. And this one we thought he was absolutely for sure having a neuromuscular disorder. And so with this, we did put him on some prokinetics and nutrition support, but unfortunately he continued to have further and further dysfunction of the gut, and ultimately succumbed to it. And so that's kind of the real deal gastroparesis, if you will, and for lack of a scientific term. But as you know, there's some that it's unclear who has what. And as you know, gastroparesis is almost like a concept that is poorly defined. And so generally we, without any biomarkers, we're kind of left in the dark a lot of the time. So this at least helped confirm that we did think there was something truly going on in his gut, but only time will tell as to what, as we study these disorders more. Here's another case, 41-year-old female. She has type 1 diabetes. And of course, anybody who has diabetes and nausea and vomiting, we all often assume that it's diabetic gastroparesis. And she did have some neuropathy, and she was on narcotics for that pain. But she also had anxiety, depression, and used cannabis fairly regularly. And obviously in Canada, this is a big problem, just because recreational cannabis is legal, and so people have access to it. And she actually had symptoms, with nausea, especially in the morning, which is very, very suggestive of cannabis hyperemesis. And she had slow gastric emptying. And so I call this the trifecta. So she comes to me and, is this diabetic gastroparesis? Is it cannabis hyperemesis? Or is it just medication side effects? Or is it a combination of all of those things? And it can be very hard to know. So when we did her BSGM, I was actually fairly pleased to see that it was relatively normal. And you can notice that it becomes almost like pattern recognition with the spectral analysis. But the frequency was in the right place, the stability was there, and the amplitude was good, and there was a good meal response. Similarly, her symptoms were mostly continuous in terms of especially the nausea and the pain. And so, based on that, despite, the slow gastric emptying test, my clinical diagnosis was that actually her symptoms were more consistent with cannabis hyperemesis as opposed to an underlying diabetic gastroparesis. And so we really focused more on the cannabis use reduction in her, and we had some success with that. Now, of course, the opioids also overlay things, but we didn't see a lot of disruption to her spectral profile from being on the opioids. And so being able to see through that that her stomach is able to generate a normal meal response was very reassuring. And so, yeah, that was good. Now, as has been pointed out, Daniel, in your talk yesterday, sometimes patients don't like to be told that they don't have gastroparesis because there's a lot of tied into, having that diagnosis, and certainly if they're on disability benefits for a diagnosis that you're trying to reverse, there can be some pushback on that. But in any case, that I felt that was a good insight that it provided. And then finally, we've got a young woman here, and this is a woman that has a lot of history of possible things, and she's had a lot of healthcare utilization through her whole life, a lot of specialists, a lot of tests. And of course, when you do many tests, you may get a few that are slightly abnormal. And so, but a lot of her diagnoses sort of hinged on this. And so she had possible rheumatoid arthritis, possible IBD, but she just got worse and worse with eating, with a lot of symptoms, with pain, with diarrhea. And she was investigated very substantially with the $1 million workup. And she even went as far as to have a full thickness intestinal biopsy, just because we couldn't figure anything out. And of course, multiple specialists were involved and too many cooks in the kitchen and that sort of thing. And so everything was actually normal, or relatively normal, certainly not enough to hinge a diagnosis. And so there was also a question of perhaps even factitious symptoms. And so ultimately she got on peg tube feeds. She had a lot of pain with that and intolerance. And so it was ultimately decided to move forward and even put her on TPN because she was not tolerating anything. And presumably she had penned up this motility, but she wasn't able to tolerate the meal. She vomited when she took the gastric emptying meal. And so once she had the line in, she actually had line sepsis a couple times in 5 months. So this is a very high-risk young woman. She's on TPN. We didn't really know what was going on. And when we did the BSGM, we actually found that she had a relatively normal meal response when she took the meal. Now, the thing is that you can do the Alimetry with a peg tube. You can actually cut it down the middle and you can slide it under the peg tube. And so we did that with her. And so what it does show is that she has a good, stable meal response to an incomplete meal. Of course, she couldn't handle the whole meal. But what we did see was a good response to the meal. And the amplitude was high, but I'm thinking that that's really more because we had the peg tube, and it's really pulling the stomach right up close to the array. And so that would probably be the reason for that. And you can see that her symptoms are really quite meal-related. And so this also, I felt, was not consistent with intestinal dysmotility to the point where she would need TPN. And so we were able to get her off TPN. We almost had to because we didn't really have a lot of choice with all these line sepsis things. But based on that, we felt that there was almost certainly an element of visceral hypersensitivity here at play. And we really tried to de-escalate things by getting her back onto enteral feeds and ramping up the treatment for visceral hypersensitivity. And so getting people off TPN or de-escalating nutritional interventions has actually been a common theme and seen elsewhere. In New Zealand, Charlotte Dacre and Chris Cedarwall just published a series of patients that they studied 50 patients with severe symptoms, and about 10 of them were on TPN or nutritional support, and they were able to actually get a lot of them off TPN or de-escalate to enteral feeding. Just because when you look at the rosters of people who are in nutritional support programs, often we don't have a really good idea of what's causing their gut symptoms. And some of them do not actually necessarily need to be on parenteral feeding. So that's, this is just an outline of some of the cases that I've seen and where I've found that it's been helpful in my practice. These are actually problem groups of patients that we all see, especially in the motility world, where they're quite complex, and it is nice to have some insight or some guidance as to what's going on. And based on the experience to date at many sites, we've been able to come up with an approach to how to manage these disorders, or how to process through the findings. And so with the spectral analysis, if it's low and it looks like a gastric neuromuscular disorder, you treat it as per gastroparesis guidelines. In other situations where you have high amplitude or a normal spectral, you can use it with the gastric emptying test in conjunction to help further define whether you want to use prokinetics if it's slow, or just manage per symptoms. And then similarly, if the spectral analysis is normal, then you can actually just go to the symptom profile and manage in that way. And it can definitely point you towards more an EPS versus PDS versus non-gastric type approaches. And so I've found that very helpful in my practice. So anyways, again, in my practice, I've found that it's useful. These are early days, though. And so we definitely need more data, more people to try it in their practice, see what they think. We've got a lot of interest and a lot of opportunities to do that. But I found that a normal spectral analysis helps me rule out gastroparesis. Obviously, it's not with 100% confidence, but certainly with a lot more than existing tests. And on the converse, if you do have spectral abnormalities, and particularly that neuromuscular one, that helps me rule in gastroparesis, at least with a lot more confidence, especially in situations where there might be some visceral hypersensitivity overlay. And then the symptom profiling helps direct DGBI management. So, as I said, there's a lot of data coming in. We've got quite a few studies on the way with various collaborators. In the last 6 months, we've come up with normal values, papers on this phenotype characterization, the test interpretation, technical guidance, and reviews as well. And so, obviously, more to come with the the wellness survey, which can talk about stress, anxiety, and we could talk more about that. But stress, anxiety, and depression, the questions are actually based on the GAD-7 and PHQ-9 and a stress inventory. GPOM studies is something that we're very interested in. Antiduodenal manometry, scintigraphy, head-to-head scintigraphy papers come out, and other studies with community gastroparesis symptoms and pediatrics and so on and so forth. So it's a growing body of evidence that we're very much interested to hear more about and share with you. So thank you.